Hello, and welcome to the Pediatric Emergency Care Coordinator Resource Series. These series is presented in collaboration by the Pediatric Committees of the Massachusetts College of Emergency Physicians and the Massachusetts Emergency Nurses Association. The presentation today is Teen Suicide, #1 Killer. My name is Maureen Curtis Cooper. I am a pediatric emergency nurse educator. I have had 37 years of experience at Boston Medical Center in the pediatric emergency room as a senior staff nurse. I was director of the Emergency Nurses Association Board of Directors from 2016 to 2018. I spent 8 years working with the Board of Certification in Emergency Nursing, developing the CPEN exam. And I was the 2019-2020 member of the National Emergency Nurses Pediatric Committee, and I was on the committee for the National Emergency Nurse Pediatric course, 5th revision. So I have no conflict of interest, and currently I am the chair of the Massachusetts Emergency Nurses Association Pediatric Committee. So today, I would like you to meet Alexandra Bolaros. She was a popular junior female in a western suburb of Boston. She was number 3 in her class. She dreamed of going to MIT. She was loved by both the adults in her life and her teachers, and she had a lot of friends. And she recently was the lead member of her all-female robotics team that had just won a slot in the World Championships. This article about Alexandra was in the Boston Sunday Globe front page feature in June of 2018. Her diary entries actually told a different story over many months. And she had poor self-esteem. Despite that she was driven in her academics, she was number 3 in the class, but she still felt like she was not worthy. Because she wasn't the very top of her class. She spent days convincing herself to do self-harm with article entries in her journal saying, do it, do it, do it. And she told her friends in a very laughing manner that she was suicidal. I have to go home. I've got to get this done or I'm going to kill myself, is what friends said. She often said. She really hid her true depression from her family, friends, and her therapist. Her family did recognize that she seemed to be stressed and that she was seeing a therapist. But after months of debate, she jumped off the overpass into the oncoming traffic of the Massachusetts Turnpike, where her father found her and her diary. So when we talk about suicide, it is defined really as a death caused by a self-directed, injurious, multifaceted behavior with the intent to die as a result. Suicide ideation or attempts account for actually half of all emergency pediatric psychiatric visits. But on the other hand, only 1 in 8 attempts actually shows up in the emergency department. Completed suicide rates have tripled over the last 3 decades. So it's really imperative for us to take all statements, attempts, threats, or just as seriously, even if they appear manipulative. And even in my own family, my niece was very manipulative and she wanted a cell phone. Her parents didn't feel she was ready for one with the responsibility, but she tied a scarf around her neck and tied it to the ceiling fan in her bedroom and was jumping off the bureau. So even though it seemed to be a very manipulative thing, she picked a very lethal way to demonstrate it. So when we even know that the truth is the manipulation, we really have to take seriously all statements about suicide. Suicide by the numbers. It's the second leading cause of death in the adolescent age group 10 to 24. And in fact, last year there were 6,488 deaths. This is the first time year that reported a drop in the deaths. In 13 years. And in fact, since the 1990s, there's only been an upward slope on the numbers of deaths. In the age ranges 15 to 19, they account for 14% of all suicide deaths, and school age group 10 to 14-year-olds count for 8% of suicide deaths, and it's still the second leading cause of death in these age groups. Based on the small amount of numbers of deaths, the suicide rate for females aged 10 to 14 really has significantly increased from 0.6 per 100,000 in 2000 to 1.7 per 100,000 in 2016. You really have to think about the pandemic, well, the seriousness of suicides. There are about 800,000 suicides worldwide, so it's just not a problem in your emergency department, and it's just not a problem in the United States. It's actually a worldwide problem. So the suicide attempts are common, and every 2 years since 1991, the CDC has done a youth risk behavior study. The last data that's available is from 2017, and what they do is they interview 200,000 high school students across the U.S. In carefully selected areas, both inner city, urban, or suburban, rural. So, but for the last reported results in 2017, 19% of all high school students seriously considered suicide, 15% had a plan, 8% actually made an attempt, and 2.5% had a resulting injury from that suicide attempt. So there are, what about the 2019 COVID-19 pandemic impact? Well, it really does have a lot of psychological consequences, and fear, anxiety about the illness, not only for themselves, but other family members, isolation, and interrupted connectedness to school and peers, and a sense of purposelessness. There are the visits increased for mental health visits in this past year, 24% in the 5 to 11-year-olds and 31% in the 12 to 17-year-olds. And there's been a 10% rise in adolescent visits with concern for suicidal or actual suicidal attempts from 2019 to 2020. The implications for us as emergency nurses is really we need to monitor the indicators of child's mental health, promoting coping and resilience, and expanding access to services to support children's mental health. They're really critical, not only during the pandemic, but in the post-pandemic area. And we have learned from the studies that were done post-Katrina that 2 years out, there are still a lot of increased suicides. So what they found was that comparing the COVID impact here, comparing the 2018 to 2019 suicide rate, it actually declined by 2.1%. Suicide rates for females declined 0.2%, and for males, they declined 1.8%. But from the studies that they've done post-Katrina, well, 2 years out, the suicide rate went down during the crisis, and then as life began again after Katrina, 2 years out, they would notice that there were really a lot of long-term sequelae, increased suicidal ideation and suicides. So do we learn from lessons from Katrina for post-COVID? Will we start seeing that increase in suicidal ideation and suicidal attempts? So we need to just keep our eyes out and be really proactive in trying to intervene and mitigate this problem. So there's some of the red flags. What are the red flags we see for that increase for suicidal rate? Well, if there's a history of a psychiatric disorder, especially depression, if there was a previous suicide attempt, if there's family history of mood disorders, if there's any physical or sexual abuse of the teen, bullying, especially cyberbullying, is a huge red flag for suicide. And I think here in Massachusetts, we're all aware of Phoebe's law. Phoebe was an adolescent, 14, I believe she was 14, from the Springfield area, and she was cyberbullied, and there was actually criminal charges brought and resulting in a cyberbullying law passed by the Massachusetts state legislature. Any exposure to violence is an increased risk for suicide, and then access to means. So do they have an idea that they want to commit suicide, but do they have the means to do it? So is there a gun in the house? Are they unsupervised and unsupervised and have access to sort of medications that they can overdose on? So those things. And so do they have to have the access to the means to, and that's an increased risk for suicide. So what are the warning signs for pediatric suicide? Well, is the path warm? So is there an ideation for suicide? Any substance abuse connected with the teen? Purposelessness, and we just mentioned that COVID-19 has created a lot of purposelessness in a lot of folks. So this is a huge area for us to be concerned about. Anxiety. Do they feel trapped? Who hasn't felt trapped in the last year when you've had to do all that social isolation? Is there a sense of hopelessness? Withdrawing from family, friends, or society? Any anger, recklessness, and mood changes are all key warning signs for pediatric suicide. So the Joint Commission in 2021 has the National Patient Safety Goals, and one of them is to reduce the risk for suicide using a valid site-specific screening tool. So there are many tools out there, but if you're using them, make sure that it's an emergency department site-specific. Two of them, the Joint Commission does have a website out there that listed here on this slide that actually gives you resources if you're trying to implement this patient safety goal. And the two of them that are age specific and site specific are the ASQ, or the Ask Suicide Screening, and then the Columbia Suicide Severity Rating Scale. And these are available from the website listed here. The Ask screen is for 12 to 21-year-olds, so it fits right into this age group that we're talking about today. And then the Columbia Suicide Severity Rating Scale is also in this age group. It's validated for age 12 and above. Your Emergency Nurses Association has actually helped us to find some validated tools by doing a clinical practice guideline on suicide risk assessment. And they have found that the two instruments were given a B level of recommendation. So the Ask tool was given moderate amount of evidence that supports a valid, feasible, and reliable tool for the initial assessment of suicide in the emergency department. And the Columbia Suicide Severity Rating Scale was also given a B rating for moderate evidence that supports the use of this tool to evaluate the lethality for discharge from the emergency department. So how do you use the Ask? It takes about 20 seconds to complete. And while we're talking about this, when we think about the evaluation of suicide in your emergency department, it's really a three-tiered evaluation. So you do this brief screening, and then you do a brief safety assessment, and then a full psychiatric safety evaluation. So this Ask actually only takes about 20 seconds to complete. So you ask 4 questions, and if any one of them answers yes, then you have to ask, are you having thoughts of killing yourself right now, or within the last 3 months? Because that's what the Columbia severity rating scale will look for. So, so do you wish you were dead? Do you feel like that you or your family would be better off if you were dead? In the past week, have you been thought of killing yourself? And have you ever tried to kill yourself? So these are the quick questions. There is no evidence that by asking suicide questions, it puts the idea of suicide into teens' heads, because if they're thinking about it, they've already thought about it before you brought up the subject. So for the Columbia Suicide Severity Screening, you ask questions 1 and 2, and if you get a yes, then you ask questions 3, 4, 5, and 6. And if there's a no, then you go directly to question 6. So the items 1 and 2 are get a yellow if you answer yes to them, and you would get a referral at discharge. Items 3 and 6, and 6 is the question is, have you ever done anything or started to do anything or prepared to do anything to end your life? And if they answer yes to that, but then you ask them, well, when was that? If it was over 3 months ago, then they get a referral at discharge. But the red, if they answered 4, 5, or 6, being under 3 months, then it's an immediate behavioral health referral and safety precautions are initiated. So do suicide screenings work? Well, in 2016, University of Massachusetts, right here in Worcester, Mass, did a study of the universal suicide screening in the ED, and they found that they looked at suicide screenings of 236,791 ED visits over 5 years. And once they looked at universal screening, that they found that they over the 5 years as they instituted it, they picked up from 26 to 84%, and so then detection of the suicide risk rose from 2.9 to 5.7 as the screenings became more universal. So they really do. We really do pick up patients who have need to be evaluated for suicidal thoughts by just asking the general screening. So the screen's positive. So what is your what do you do now? So first of all, if there's been an active suicidal attempt, medical stabilization is your number 1 priority, without question. So you immediately triage them to a safe room in the emergency department, or you may even need to put them in your acute side if it was an ingestion, for example, or a gunshot wound, or an aborted strangulation. Obviously, they need the stabilization first. They need constant one-to-one observation. There are some immediate questions that we need to ask. Obviously, they're going to be referred to a mental health clinician. We need a prompt assessment of suicidal risks. You want to separately interview both the patient and the caregivers and others that were involved. So that collateral information that you can get from medical records, from the school, therapists, other behavioral staff that have come in contact with this teen, are all places where you need to get your full history of this child. So there are some initial questions to ask. First of all, are the emergency care personnel safe in approaching the child? Do they have any toxins on them that might be unsafe for us? Is the patient safe in the environment? Are there serious medical conditions present that we need to take care of immediately? And who is going to supervise this child in the emergency department? You can't rely on family. Obviously, you need to have one of your staff to supervise this one-to-one observation. And then the other question is, will the child return home, or will the teen be hospitalized? So what about adolescent confidentiality? So, we usually say, we have patient confidentiality. What you say here stays here, except if someone is hurting them, if they want to hurt someone, or if they want to hurt themselves. So always safety of the child and safety of the people in their life trumps that confidentiality. So I think that one of the things that we really want to do is we want to have an open and trusting rapport with the patient, and that don't promise them that if you tell me I won't tell anyone, because if any of these 3 conditions occur, then we are obligated to tell the appropriate people. So what is the pediatric suicide evaluation and management? I think it's really important that we as practitioners be very comfortable discussing suicide and thoughts of suicide. You want to pose questions that are short, to the point, and non-judgmental. The question should also to make sure that you take into consideration signs and symptoms of major depression. It's really important that you're an active listener. You have to have a calm demeanor, neither minimizing nor disapproving what you're hearing. So for the physical exam, of course, we want vital signs, we want level of consciousness and orientation. You want to look for any manifestation of any of the toxidromes if they've tried to poison themselves. You want to look for signs of recent or past suicide attempts. You want to look for any signs of physical abuse and just their general overall medical condition. For the nurse patient report, it's so important to spend those critical first few moments when you're introducing yourself to the patient so that you can build a bond that's trustworthy. There are some things that we can say and things that we shouldn't say that will certainly help. You can say things like, I can see why you're so upset over this. I'm really glad you're here. We will figure this out together. And then you can compliment something, oh, I really like your nail polish. I like your hat. You've got a Bruins shirt on. Are you a Bruins fan? So something that will connect to them as a person and as them as a unique patient that you're dealing with. Really, there's some things that you really should avoid saying. You can't say you're way overacting to the breakup with your boyfriend or girlfriend. There are many other fish out there. You don't want to say that. You don't want to try to talk them out of suicide. You really want to understand where they're coming from. You can't assume or say that you should have known better than that. Well, who's to teach them? They say the apple doesn't fall far from the tree. If the family has a history of psychiatric disorders, then this is what they are learning. So, and there's a lot of, we all know there's a lot of bad information out on from Dr. Google. So you really don't assume just because they look like they're adult size that they should have some pretty good thought matters on this. You shouldn't lecture them about right versus wrong. You can't say things like, we didn't cause this problem and we're not going to be able to fix this problem. I know that in the emergency department that we do not do definitive mental health care. We start the process and it's a long, often lifetime process. So, we need to avoid statements like that. And you really can't promise discharge from the emergency department because we don't know what the outcome is going to be once they've had their full mental health evaluation. So for the emergency department psychiatric evaluation, it's really only done after the child or the teen has become medically stable. We need to be evaluated by mental health clinicians. It's really wonderful if you work in an emergency department that has specific pediatric psychiatrists and mental health clinicians. But the bottom line is they just need to be evaluated by a mental health clinician. There's got to be a determination of a risk for subsequent suicide attempts or completions. You want to identify any predisposing or precipitating factors. There needs to be a full mental health status exam, and then your mental health clinician will come up with a recommendation for the level of care that this teen will need, either inpatient, partial hospitalization, or outpatient follow-up. So the idea of patients who have really high risk for suicidal ideation, and they have a plan and they have means to complete that plan. It's absolutely critical that we have a suicide safety plan. And remember that passive suicidal ideation can progress to active suicidal attempts when they have a plan. The best practice really focuses on generating a safety plan between the clinician and the teen. So the purpose is to provide that teen who's experienced those suicidal thoughts with a specific set of concrete strategies to use to decrease the risk of suicidal behavior. And it's really important that the teen save that plan, that it's written down in some form. you know, in their cell phone, on a piece of paper that they put in their wallet. It's got some place that they really can readily access when they're having a crisis. So the steps of the plan is that they should know what their warning signs are. What are their internal coping strategies? Things I can do to distract myself without contacting anyone. Then this third step is if there's a social situation or people that can help me distract myself from these thoughts, who can I ask for help? What professionals or agencies can I contact during a crisis? And really, how do I make the environment safe? So this involves the family. If there are guns in the family, in the home, you know, how do they, you know, it would be best if they got them out of the home. But if that's something they're resistant to, how do they keep the safety of those, you know, gun locks, trigger locks, keeping the ammunition separate and locked, all of those things. If there are pills in the home, how do they secure them so that they won't become the means for a suicidal ingestion? So, what other things will the family be able to accommodate? You know, will the child be left alone, or the teen be left alone? And if your parents have to work, and we all understand that they have to work, who is going to be supervising that teen during the immediate future? So all of these things will need to be considered about making the environment safe. So for high risk suicide treatment options, really it is hospitalization. They need to have a thorough evaluation and get on medication if they needed to treat some underlying psychiatric disorder. More frequent psychological interventions if they've already are seeing a therapist, and what they need to be mobilizing supports in crisis intervention services for the high risk patients. Um, and then what about the emergency department management for disposition? And so either voluntary or involuntary hospitalization, either it's an inpatient, full inpatient, or a partial treatment. And this is the patient, the teen, who has the suicidal behavior or very high risk for it. It's the standard of care, but remembering that there are no high quality studies that demonstrate that it's going to prevent a future suicide. You want to maintain in the emergency department that one-to-one observation until they're transferred. If they're transferred by EMS, you really need to inform your EMS providers that of the suicide risk. For outpatient treatment, it's the best option for low risk patients. It's contingent again on that safety plan we just discussed, and you want to have make sure that the suicide means of carrying out a plan are mitigated in the home, and then there is also intensive home therapy for crisis stabilization. So prevention of suicide in the teenage population, the CDC has published some suicide prevention strategies, and one of them is a school-based gatekeeper training to reduce the student suicide attempts. And there are also other community-based interventions that may temporarily reduce suicide attempts and mortality in youth. And those are other projects that programs that you can refer these teens to. So just in conclusion, I just want to say that suicide is a permanent solution to a temporary problem, and everything that you do in the emergency department to mitigate and help these teens recover is critical, and especially as we come out of our post-COVID pandemic era. Thank you very much for watching this video, and be sure to tune in for the other ones that are listed on the website. And thank you and have a great day.